Okay, now that we're almost at the end of endocrine, it's time to talk about the pancreas. Pancreas anatomy was covered in GRT, so what we're focusing on is firstly the difference between the exocrine and endocrine pancreas. The exocrine pancreas contributes most of the pancreas, so 85%, and includes the acinar cells and ducts, which secrete things like digestive enzymes. The endocrine pancreas is made up of islets of Langerhans, so these things here and here. These are composed of alpha, beta, and delta cells, which secrete hormones. And the two key cells to understand are beta and alpha cells. So beta cells secrete insulin. When there is a rise in blood glucose, so after you eat or the fed state, beta cells release insulin to bring down the blood glucose. Alpha cells have the opposite effect. In the fasting state, alpha cells secrete glucagon, which act to increase blood glucose. This is clinically relevant as well, as glucagon can be used to treat hypoglycemia or low blood sugar. So what exactly does insulin do? So insulin facilitates the entry of glucose into muscles, adipose, and other tissue. In many tissues, muscles particularly, GLUT4 is the main transporter used to uptake glucose, and that is made available in the plasma membrane through glucose. When insulin is low, these transporters float around in the cytoplasmic vesicles, but when insulin binds to receptors on our cells, these vesicles fuse with the plasma membrane, and hence glucose transporters allow more glucose to be taken up. Other organs, like the brain, however, which always need glucose for energy, are insulin independent and use a different transporter. Insulin also has other effects, promoting synthesis of fatty acids, glycogen in the liver, and inhibiting breakdown of fat in adipose tissue. Okay, so let's chat now about diabetes. Diabetes mellitus is the main condition. Diabetes mellitus is the main condition I'll talk about in relation to the pancreas and the endocrine system. So diabetes means to pass through, and mellitus means sweet, which probably reflects the glucose in the blood. Diabetes means to pass through, and mellitus means sweet, which probably reflects the glucose in the blood and urine. So in diabetes mellitus, there's an abnormally increased level of glucose in the blood, either because the body is not producing enough insulin or because the body cannot respond normally to insulin. To diagnose diabetes mellitus, we look at HbA1c levels, fasting glucose, and or random glucose. The levels I've noted on the slides are helpful to memorize. Let's run through type 1 first. So type 1 is also called insulin-dependent or juvenile onset, and this is caused by a deficiency of insulin. The body itself, the immune system, is destroying the pancreatic beta cells, so no or very little insulin is produced. And this typically presents in childhood and is less common than type 2. Now, in type 2 diabetes, it's also called non-insulin dependent or adult onset diabetes, where in type 1 we have the body unable to produce insulin. In type 2, the pancreas is still producing insulin initially, but there is insulin resistance because the tissues fail to respond to insulin. And so what happens is the pancreas then compensates with higher levels of insulin, working overtime, but eventually it slows and can no longer produce insulin as effectively. Type 2 has a stronger genetic link than type 1, so family history is important. Here is a summary of type 1 and type 2 diabetes. Remember, type 2 is more strongly linked to genetics and has more modifiable risk factors. Both present with similar clinical features. Lifestyle interventions are the first line, but in type 1 diabetes, there is no treatment at present except insulin, whereas more drugs are available for type 2. Diabetes. Now, type 1 has more abrupt symptoms and decay, which we'll talk about in a moment, and can develop suddenly. Type 2 is more subtle, later, and slower onset. High blood sugar symptoms include increased thirst, hunger, and urination as the kidneys try to excrete more water to dilute the glucose. Other symptoms include blurred vision, drowsiness, and nausea. Diabetes leads to a range of complications, and it is important to monitor diabetic patients for these complications. High blood sugar, vessel damage because of reactive oxygen species, inflammatory response, pro-inflammatory cytokines causes damage to the arterial walls, thickening of the basement membranes, and hardening of the capillaries. So high blood sugar damages nerves in the peripheral nervous system and causes issues like pain or numbness. The kidneys have to work harder and to get rid of excess blood glucose. In the eyes, high blood glucose and blood pressure can cause damage to the blood vessels in the eyes, causing retinopathy, cataracts, and glaucoma. Macrovascular complication occurs as high blood sugar accelerates atherosclerosis from endothelial dysfunction. Diabetes increases the risk of many diseases such as coronary heart disease, stroke, cerebrovascular disease. In the periphery, blood vessels are narrowed, reducing blood flow, and this leads to slower wound healing. Combined with neuropathy, this causes an issue as injuries such as ulcers on the feet go undetected, become infected, and cause gangrene. Diabetic ketoacidosis is more commonly associated with type 1 diabetes, and it occurs when blood glucose is extremely high and acidic ketones build up, causing hyperglycemia and ketoacidosis. Patients with DKA can have Kussmaul breathing, which is deep, laboured hyperventilation to remove carbon dioxide and increase blood pH. They may also have hyperkalemia, a compensatory mechanism for ketoacidosis, as the body moves H plus ions into cells and pulls potassium out into blood. So that leads to a high anion gap metabolic acidosis, and this is emergency. And you want to first treat with IV fluids for dehydration, administer insulin to lower blood glucose, and monitor electrolytes, especially potassium, because insulin can cause a shift of potassium into cells, causing hypokalemia. Is associated with poorly controlled type 2 diabetes mellitus. There's more severe hyperglycemia, but no ketoacidosis associated with DKA, so that's how you tell the difference. And because blood sugar is so high, osmotic pressure pulls fluids from cells into the bloodstream, leading to severe dehydration and cellular damage. This severe dehydration causes neurological signs and symptoms, including mental confusion, drowsiness, and seizures. Now, diabetes drugs we more or less have to just rote learn, but I think it's useful to understand the mechanism of action. Firstly, let's think about drugs that can either increase the release of insulin or increase insulin sensitivity. Sulfonylurea and glutamides block potassium channels and increase secretion of insulin. Over here we have incretin mimetics and DPP-4 inhibitors, which are similar. Incretins are hormones released after eating, and they augment the secretion of glucose. So mimetics, glucagon-like peptide 1, has the same effect. DDP-4 inhibitors block the enzyme peptidase 4, which breaks down incretins. So there are more incretins in the blood, again leading to increased glucagon secretion. On the other side, we have drugs that increase insulin sensitivity, such as metformin, bigonide, and TZDs, which help the body tissue respond to insulin. Others to mention are acarbose and SGLT2 inhibitors. Acarbose is an oral medication which inhibits alpha-glucosidase. Acarbose is an oral medication which inhibits alpha-glucosidase in the gut, which breaks down complex carbs. SGLT2 blocks sodium glucose transport in the proximal tubules, increasing glucose excretion. Now, the guidelines change as more research is done, so for the most up-to-date information, I'd recommend checking out the Therapeutic Guidelines. And here we have a lovely table for you to memorize. I think the mechanism of action and side effects are most important, and ePharm is also a super useful resource. And we've come to the end. As always, shoot us a message if you have any questions. Thanks, guys.